Okay, continuing on with lecture 25. Last time we talked about the history of herpes, which has been with humans for thousands of years. But in the last almost 50 years now, we've had some medications that can be helpful in reducing the severity and duration of outbreaks. And we talked about the concept of disease mongering, making people feel like this was a horrendous disease that they must absolutely go to the doctor and get treated for, which isn't true, although going to the doctor and getting treatment can be helpful, and that these are really common viruses. So more than 90% of Americans have HSV1 and more than 20 to 50% have HSV2. So let's talk about the actual infection itself and what it is. So herpes is a DNA virus. It only infects humans, and there are two types, HSV1 and HSV2, as I mentioned. So HSV1 really likes to infect the lips, right around your mouth, particularly that region right in between your lip and the skin. That's its favorite place to infect. But interestingly, HSV1 can also infect the genitals. It's like, not my favorite, but I'll make do. HSV2, however, is a below-the-belt virus. It only infects the genitals. It doesn't like to infect the mouth or the lips at all. How do you get it? How is it transmitted? So it's direct contact of skin or mucous membranes with infected secretions or skin, right? So if somebody else has this virus on their skin, you rub your skin against theirs, right? That's how it's transmitted. And as we talked about, when Aunt Sally gives you a kiss when you're a little 3-year-old, that can be enough, right? Just that direct contact right there can transmit the virus. Now, it is most contagious when somebody has symptoms or sores, but can also be transmitted during times when people are asymptomatic, which is why it is so successful, right? It's kind of shares a similarity there with chlamydia. So very successful at infecting lots of people for that reason. The average onset from exposure, from actually getting infected to developing symptoms, is 5 days. And most people who are infected will develop symptoms. So what are those symptoms? What happens if you get herpes? Well, a lot of you already know this, but for those of you who don't yet, here's what happens. First, you get this prodrome, like a little tingling or a little itching or kind of a burning sensation or a little bit of pins and needles in the area where you have the virus. So the interesting thing about herpes is wherever you get infected with it on that particular area of your body, that is where you will have your symptoms. It's unlike other infections that can cause symptoms in different places. It's very localized. Then you start to get little tiny bumps called papules, and then those bumps turn into little blisters called vesicles, right? So they get filled with fluid. Then the fluid gets kind of cloudy. It almost looks like pus. So you get these little pustules. They look like almost like little pimples. And then they break open, and then you have these sores, and they're painful, right? This whole thing, like these are quite painful usually. And when that happens, when those pustules break open, right, some of that fluid can leak out. So when I mentioned that transmission can be due to infected fluid or skin, that's what I was talking about. And then the sores kind of crust over and they get this kind of crusty appearance, and then they eventually heal. And so it always goes through this kind of step-by-step business with herpes. It's very predictable most of the time. So if somebody has oral HSV, it's almost always going to be HSV1 because that's the virus that likes to infect the oral region. It's sometimes called herpes labialis because labialis refers to lips. So don't get confused by that. They're not referring to the labia on the female vulva. Those are different types of labia, different types of lips. So watch out for that confusion. The very first time you get oral HSV, sometimes you can get a ton of really terrible sores in the mouth as well. So that's kind of a known thing that can happen in some people. And as we've mentioned before, up to 90% or more of the US adult population has been exposed to HSV1 at some time in their lives, whether or not they've ever actually had the cold sores from it. And in those people who do get symptoms, it tends to be recurrent. So outbreaks can be triggered by stress or illness or sometimes just bad luck, right? And so that being triggered by an illness, that's where the idea of a fever blister comes from, right? You get sick with something and then it triggers your herpes to activate. It always recurs in the same place, and for some people it recurs really frequently, and for other people it hardly recurs ever at all. There's a lot of variation from person to person. But the virus stays with you for your whole life. This is not a curable infection. It's treatable, but not curable. So what does it look like? So oral HSV, right? First, you're going to have a prodrome, then little bumps, then little blisters. And right here, we're looking at somebody who's kind of transitioning from the blisters filled with clear fluid to kind of getting a little bit cloudy or almost pimply or pustule-like. And then that's going to break open and you're going to have a sore, right? So you're going to have a sore there. See, anybody can get this. It's really common. And then eventually it's going to crust over. So that's kind of the standard progression that we're always going to see. Genital HSV, we talked about, can be caused by HSV2 because HSV2 only infects the genitals, or HSV1. And interestingly, as the popularity of oral sex has increased over the last several decades, it used to not be very common back when I was in college, which was, back when dinosaurs roamed the earth, but oral sex became more common kind of after the HIV epidemic, interestingly. And so we're seeing more and more genital herpes caused by HSV1. It's not its preferred location, but it's like, well, if I must. So there was a study in 2003 actually at UW-Madison where they sampled everybody who had genital herpes that came to their student health center and found that 75% of the time genital HSV was actually caused by HSV1. So they had contracted it from oral sex, which makes sense. HSV2 is happier infecting the genital region. It's more its, groove. It's where it likes to be. And so if you get HSV2 on the genital region, you're more likely to get recurrences than if you have HSV1 in the genital region. And you're more likely to be potentially infectious with that virus even when you don't have symptoms, even when you don't have sores. So clinically, we usually like to find out or figure out if we can, if somebody has genital HSV, we like to know whether it's type 1 or type 2. So we'll often do a test from one of their sores to find out because it gives us an idea for what to expect. One note that if you do shave your pubic hair, you're at slightly higher risk of getting genital HSV because you get that loss of protective hair and that kind of micro trauma. It can create little tiny kind of tears and rips in the skin. But you can't get pubic lice. So pros and cons, right? All right, what does genital HSV look like? So first there will be a prodrome, then little bumps, and then what we're seeing here in the glands of this penis are those little vesicles or tiny blisters filled with clear fluid. That fluid will then become kind of white or yellowish and start to look like a little bit of pus. So here we see some pustules on the base of the penis. Here we now see the ulcers, right? So when those blisters break open, you kind of have these raw spots. These are very painful. This is on the vulva, obviously. We're looking at the interior surface of the labia minora. And then here's another one of those ulcers, right, after the blisters break open, all around the corona and the first part of the shaft of the penis. So very painful. So how do we know if somebody has herpes? How do we diagnose it? Usually by exam, and there are some tests, so let's talk about it. Most people that get herpes have these classic symptoms. So based on the patient's report of what's been happening to them and us looking at the sores, usually we can be very confident that that is what they have. I've only been fooled once, and it turned out that somebody had been doing some sex play with ice and snow, and they actually had frostbite on their vulva, and it ended up causing those sores, so it looked just the same. But most of the time we can tell pretty reliably that it's herpes just by looking at it, right? So people who work in student health, we've seen a lot of herpes, so we're pretty good at it. But we can also test the sore. We can take a swab, like a Q-tip, and rub it over a sore and send it for testing for the actual virus. That is useful to us if it's a genital lesion and we want to know, is it HSV1, which is less likely to be recurrent or infectious to others, or is it HSV2, which is more likely to be recurrent and infectious to others in the genital region. So we can do that, and we often will. Now, some people are completely asymptomatic. We're not sure how many. It's less than 30%, and they may never know they have the virus. Now, they can potentially transmit it to other people, but they are going to be less contagious than people who get symptoms. And this is a real challenge because we don't have a great way to test these people. There's no sore for me to test for the presence of the virus. So we can do blood tests to look for antibodies, but there's some limitations here. First of all, those tests aren't very accurate. It just has to do with the science of the way you make antibodies to this virus, and so the test gives you lots of false positives and negatives, and we know that that's not a good thing. It can cause lots of harm. The other thing is that if the blood test comes back positive, say for HSV1 or HSV2, you don't know exactly where the infection is, right? Even if it's HSV2, is the infection on the glands of the penis or is it on the scrotum, right? If it's on the glands of the penis, then using condoms will prevent transmission to a partner. But if it's on the scrotum or the base of the penis, then it might not. So it's really hard to then know what to do when you're counseling someone about how to kind of proceed with their partners. So we don't routinely do these blood tests because they're not very helpful. We also, like, if it comes back positive for HSV1, I don't know, was that on the genitals or was it in the mouth? I don't know. So if somebody has sores, if somebody gets treatment, or excuse me, if somebody gets symptoms, then we will offer them treatment with antiviral medicines, right? So acyclovir was the first and valacyclovir was the second, called Valtrex. And there's two different approaches. One is episodic treatment. This means every time you get an outbreak, you start taking the medicine. This is one of the most common ways we treat this infection because for a lot of people, right, they only get outbreaks once or twice a year. And taking medicine for it can reduce the symptom severity, meaning how bad and painful it is, and duration, meaning how long it lasts. So while these medicines aren't nearly as helpful as, say, penicillin for syphilis or Zithromax for chlamydia, where it's gone after you take the antibiotic, they do make it not as bad, right? So they don't cure it, they don't make it vanish within a day or two, but it does make it be less severe than it otherwise would. The other approach is suppressive therapy. So we can put somebody on Valtrex, for example, and they take it every single day. And that will decrease their likelihood of getting outbreaks, and it can also decrease how contagious or infectious they are to others. So if somebody gets outbreaks once a month, that's somebody for whom suppressive therapy might be worthwhile, right? Then it's worth having to take a medicine every single day. If you only get them occasionally, then it's probably not worth it. One special circumstance that you need to know about for HSV is that if somebody who's pregnant has a history of genital HSV, we have to look for any lesions in the genital tract at the time of childbirth. Because if the virus gets transmitted to the infant during childbirth, it can actually cause a devastating infection. It can infect their brain and their spinal cord and can be fatal. So Genital HSV is really common, and most people who get pregnant who have a history of genital HSV will never have this happen to them. But if there are active lesions at the time that they go into labor, we will actually deliver the baby by C-section so that they don't get exposed to that virus and their passage through the birth canal. So what about screening for herpes, right? I said it's really common, and we know that if something is really common, then it might make sense to screen for it because it's not a needle in a haystack. But let's remember our other criteria for what makes an effective screening campaign. So first of all, in order to be effective, it has to be an infection that is frequently asymptomatic, right? If you already have symptoms, you already know that you have it, right? So why would we need to do screening tests, right? It needs to be common. It needs to be serious or dangerous. We need to have a good test, and we need to have good treatment that makes a significant difference, right? That makes it worth all the effort of trying to find these cases. So let's kind of see how herpes stacks up against these criteria. So first of all, it's not usually asymptomatic. Most people with herpes have symptoms, so it doesn't meet that criteria. It is common, so we got that one. We have a type-specific blood test that looks for antibodies that unfortunately is expensive and not very accurate. So we don't have a good test, so we don't meet that criteria. Will we do anything different with the information? So even if the test were accurate, again, it doesn't tell us the location of the infection, and therefore we're not really sure what measures might be necessary to protect future partners. So we can't cure HSV, and it's not usually dangerous. Condoms can only then help if the area is covered by the condom, and we won't know where that area is if they didn't have symptoms. We can use suppressive medication in an asymptomatic person, but that can be inconvenient and expensive, and we're not sure what additional benefit that would give us, right? So we don't have studies to show us what the normal infectivity of an asymptomatic person is, and then what it would be if they were on suppressive medicine. So, therefore, we only recommend screening for the asymptomatic partner of a known HSV2 positive person, which we call a discordant couple. So let me explain. If I'm in a relationship with somebody who we know has HSV2, they have genital herpes, they've had it tested, it's HSV2, which tends to be more contagious on the genitals than HSV1. So therefore, we want to know, am I at risk? So if I'm an asymptomatic person, I've never had any sores that I know of, right? And usually you know because they hurt, right? We want to know, could I be somebody who has been infected and just asymptomatic, or am I truly somebody who's never had it before? Because if I've never had it before, then I'm at risk of getting infected by my partner. So therefore, if you test me, if it comes back negative, then we know I'm at risk of getting infected, and that might influence our decision for my partner to take suppressive medicine, right? Because they're a symptomatic person. We know it makes a big difference. If my test comes back positive and I've already been exposed to HSV2, then we're good. We don't have to worry. We don't have to do anything, and my partner doesn't have to take suppressive medicine to avoid infecting me. Because one of the things about this virus is once you have it, and you can't get like reinfected again, right? So if you're already positive for it, then you already have it, and you're not going to catch it again from your partner, which is kind of cool. So in summary, herpes is transmitted by skin-to-skin contact or direct mucous membrane contact. Most people will have symptoms within less than a week, and it's that classic progression of a prodrome with some tingling or itching or burning, and then little bumps that turn into blisters, that turn into sores, and then crust over and then heal. Some people are asymptomatic, but less than 30%. It can infect either the oral or the genital regions. If you have oral herpes, it is HSV1. If you have genital herpes, it could be 1 or 2, and it's more likely to be recurrent if it's 2, because that's the preferred environment for HSV2. Treatment is antiviral medication, which can be episodic, meaning we treat each individual outbreak, and that will lessen how long it is and how painful it is. Or you can do suppressive treatment to take the medication every day to prevent outbreaks and or prevent transmission to a partner who has been shown to be negative for HSV2. Testing, viral tests from the lesion are accurate and can tell us the type, so we usually do those on genital lesions. And blood antibody tests for asymptomatic people are not very helpful or accurate, so we only recommend them in that case of discordant couples where we know one of them has HSV2 and we want to find out, does the other one actually have it and just not realize it. All right, so that's it for herpes. We're going to continue on with 25C, introducing you to HIV.